Thank you very much. The topic that I was given was innovations in informatics enables newborn screening programs to improve efficiency, impact of next-gen sequencing and metabolomics. So I had some difficulties with this topic I was given, and I tried to tackle it by knowing what's happened in the last 2 days. Okay, so we had a lot of next-gen sequencing, we've had a lot of metabolomics by tandem mass spectrometry. So what I'm going to do is present you both sides of the story such that you can make your assessment on how innovations in informatics is required in order for us to fulfill the advances in the technology that we're being faced with. So as an overview, I'm going to give you some rules regarding newborn screening. I think it's important to have that. The current concepts in newborn screening. These technological advances that I'm referring to that have impacted on newborn screening are in these two immediate categories of genomics and metabolomics. And we've had some excellent talks in the last 2 days. Little has been broached in regards to how one assimilates all this massive information. We had some excellent talks on Duchenne muscular dystrophy and the application of NGS on the screening and characterization of that disorder, but very little has been done about how we assimilate all this information. Now, these disorders screened in the newborn period use NGS, whole exome sequencing, targeted gene analysis, and the use of metabolomics. I'm going to draw examples from these two, from case presentations that have arisen through my department. And I will do that, as I said, by using case presentations. And then I hope by doing that, you can see that there's a synergy in newborn screening. This synergy is that the screening strategy, by combining information that is generated through NGS and MSMS, combines together to provide a screening result. There is obviously a rule that one needs to apply. This tenet regarding newborn screening is that, as far as I'm concerned, and I think I've raised this during this meeting, that it is a preventative public health program, unequivocally. I was taken in by this quote by Sidney Brenner, the Nobel laureate in 2002, in that progress in science depends on new techniques, new discoveries, and new ideas, and probably in that order. And I feel that that's very much what's happened in newborn screening, because the new techniques or technologies have arisen through biochemical genetics, through this instrument that allows us, through high throughput automation, to identify these inborn errors of metabolism that were not readily identified in the newborn period in the past. And then the other aspect of the technological advances is the molecular genetics, the next-gen sequencing, to identify these Mendelian disorders or expanded panels that is available, the introduction of the screening for cystic fibrosis, not necessarily by next-gen sequencing, but a lot of us, including my colleague here, Veronica, have been doing this for many, many years, the introduction of SCID and so forth. So what I'm going to do now is bring this together to show you the impact newborn screening has. Now, we're obviously conducting this testing at this period, but it's quick to see that the advances in techniques makes anything screenable. I think Veronica raised this, and I did as well. The ever-widening gap in what is technologically possible and the services available produces enormous amounts of pressure. Pressure from advocacy groups to their respective governments to screen for rhubarb disease or screen for all of these. These are all very doable simply because the technology is available for us to do that. There is obviously a dependency on the ethical, financial issues that drive the screening for some what is perceived for the moment to be untreatable disorder. But you can see how what we do here impacts further along the track by identifying late onset diseases. This is an unwanted thing, as is carriers when we screen for cystic fibrosis. We introduce concepts of pseudodeficiencies. I also reiterate carriers. Benign conditions for which we identify an individual who will not require any clinical intervention. And then those diseases that are treatable, or untreatable or just require management. And even we can go prenatally by the introduction of this type of testing called non-invasive prenatal testing. So you can see where we're heading once we've done this screening at this point in time. And so even with DNA scans, you can detect easily 1,800 diseases in the newborn period. Raises some great privacy concerns. And there was an article in US Today and in social media regarding what this raises in terms of addressing privacy concerns to the individual. So multi-omics is what I refer to and the future of newborn screening. There is an obvious synergy between genomic and metabolomic techniques, and there's a requirement, an absolute requirement for bioinformatics. There's an enormous amount of information that is generated here, and I think I myself struggle on a daily basis to assimilate and to make sense of all that information that is generated. So if we now address the issues that are raised when one has an NGS approach, and you can have an NGS approach in newborn screening by many different ways. This is one project called BabySeq. I think you may be familiar with this group of Green and Beggs from Boston Children's Hospital, who were evaluating the benefits and risks associated by having a genetic sequencing approach in newborn screening to identify these childhood onset diseases. Well, these are randomized into two groups, well infants randomized into sequencing or whole exome sequencing, and then those infants who are most susceptible to genetic conditions in the NICU, who may have a multi-syndromic condition, and then they were randomized into sequencing or not. They, unfortunately, didn't have a great uptake. There was only 7% of those parents of those babies in NICU that chose to take up this approach, and 8.3 in a well cohort. There are obviously logistical reasons why this uptake was not as high. Questionnaires return after 1 year. There was not wanting to learn unfavourable outcomes and insurance discrimination, privacy concerns. So there was a load of issues that went against this sort of approach. And then even doctors and families found fewer benefits and more risk on this type of approach. And there was obviously the associated psychological stress and genetic discrimination that may result of finding something you never knew you had. There was another approach, next-gen sequencing in critically ill infants. Stephen Kingsmore from the Mercy Hospital had this approach where a retrospective review of whole genome sequence for explaining multi-syndrome conditions, and they had quite reasonable success. 57% using this approach had some sort of genetic basis for why these infants were critically in the NIC, in the neonatal intensive care ward. Clinically useful in 65%, specific therapy or palliation for the reason why they were there. StatSeq, a prospective randomized control study using whole genome sequences underway. Groups in Australia are undertaking this at the Melbourne Genomics Alliance Centre. They're using these rapid single whole exome sequencing for the diagnosis, quite good diagnosis rate of 47%, changed the management in patients by 57%. I mean, these numbers are small, but you can see the potential that this approach would have. There's immense opportunity in saving costs. You may very well identify a condition in which just simply a vitamin replacement is going to correct it, or a change in your treatment. Planning to evaluate trio-based, mother, father, and the child with this sort of turnaround is the approach that this group is using. And there are other groups. There's one group in Adelaide who are doing quite a lot of work in single-cell pre-implantation, which is quite a significant resource that people use in order to determine pre-implantation with certain diseases. This presentation was done by John Christodoulou and David Dimmock at the last ICIM, and I took quite a long time to assimilate all this information. So there are other ways in which one can use NGS to approach newborn screening, either panels, whole exomes, whole genomes. You can get specific panels for just a short number of genes if you identify that the condition the infant would have is an organic aciduria. The Roche 1KD provides you the opportunity of doing targeted genes for quite a few hundred. Whole exome sequencing has the problem of doesn't capture mitochondrial. You need custom design for additional mitochondrial baits. Parallel NBS approach for mitochondrial disorder using this sort of ion torrent approach. Whole genome sequencing, and the advantage is that you do capture the mitochondrial, 30 times coverage for nuclear, 20,000 on coverage, mitochondrial genomes as well, should be able to detect quite a number of mitochondrial deletions and mutant load. But this is very time consuming, very expensive. Our department has changed in the way we have introduced next gen sequencing, in that we had good quality scientists, very high end quality scientists who were doing a lot of wet chemistry stuff, and their activity has now gone to dry chemistry stuff because of the need to assimilate all this information. So we have specific panels in our department in biochemical genetics for those conditions that arise quite often. And we have these rather extensive panels that enables us to target those specific mutations, those specific genes that are quite common in our screened population that arise at increased risk by the use of tandem mass spectrometry. And what I'm going to do is I'm just going to give you a couple of real examples of how the synergy between a metabolic approach or a metabolomic approach and genomic approach works together to resolve a problem. So I'm going to use an MCAD and VLCAD, but before I do that, one could sum up NGS, in my opinion, as should it be the first tier? Probably no, simply because NGS is a relatively cheap, but you must think of what you want to answer, because the analysis will not do the magic for you. In other words, you'll end up with more problems and unresolvable issues using this approach. And so as a second tier in newborn screening test, I think that works quite well, and I'm going to give you some case examples of how that happens. So the combination with this approach, I think, is the most appropriate way of going. So in newborn screening, the really important things that we always must ask ourselves: can we find the cases? Does the diagnosis do any good? Does it do any harm, and can we afford it? So this approach of the informatics that is required is resource requiring, and it is not an easy thing to do. Simply the introduction of mass spectrometry has revolutionized the way we approach the clinical interpretation of analytical results, where a single spot, by use of mass spectrometry, generates hundreds and hundreds of different compounds and analytes, and you have to be able to interpret it. So this tandem mass spectrometry, enabling the identification of these disorders that we spoke about today, including that which we broached with the lysosomal storage disorders, those molecular techniques that were discussed, are all coming together in this expanded newborn screening. So the major expansion of this has been as a result of this instrumentation, because of the high throughput and the automation enables this to be conducted. We've been extremely proactive in this area. We got our first machine in '98, our organic chemist, and then over a period of time we've just contributed to that by different instrumentation as technology improves. But what we've managed to do as a result of that is just generate more and more data, requiring an absolute need of a bioinformatics software system to enable you to do that interpretation. And if we look at what's changed in terms of newborn screening techniques, I referred to a discrete test versus a profiling. And there's a huge paradigm shift in the way in which we look at these results in a newborn screening laboratory. What I say is a discrete test, we're measuring from one spot, one compound, one disorder, and we're able to do multiple analytical methods for multiple diseases. So this is a discrete test. So you measure TSH, you've got a reference range, and it's an easy, simple, relatively simple process once you've got established all your QC and QAP to afford that to readily to do. And so this approach with mass spectrometry is now moved into the realm of profiling. And you can no longer use this approach when you've taken on this technology, because simply you're inundated with the amount of information that just is too difficult to interpret and so forth. These inborn errors of metabolism are thousands of different disorders. This is the online metabolic and molecular basis of inherited disease that gets updated often enough. But the underlying basis of all of those metabolic disorders is this little cartoon where you've got a substrate going to a product, you've got a defect in the enzyme or its cofactor. The cell has the ability to shunt to other pathways to remove the accumulation of this toxic substrate, and mass spectrometry enables that to occur quite readily and very easily. So in the past, what has happened? Prior to the introduction of tandem mass spectrometry, we would have a clinical presentation of an individual who's come from the child developmental unit, and you have a mild intellectual disability. I think this was a 2 or 3 year old child. And so the classical way is to put 100% of those samples through these high intense, very expensive systems of plasma amino acids and urine organic acids to confirm or exclude this child development unit. And this baby ended up having actually malonic aciduria. This has been revolutionized by tandem mass spectrometry, as you can see from this cartoon, that now a very small percentage of the samples that needs to go through these very expensive processes, and we've now moved on to yet another mass spectrometer to do the organic acids and amino acids to confirm or exclude using second-tier tests. There is a level of complexity that arises from using this instrumentation, and you really need the fundamental requirements of a bioinformatics system, statistical methods, reference ranges, biochemical genetics, and an understanding of biochemical genetics to make sense of all these numbers. Otherwise, if you have a discrete test approach, your false positive rate and your requirement to follow up these patients is just enormous. So I've already touched on these factors in regards to how much data is generated. You need a software system and a population distribution for reference ranges, and a good, sound knowledge of generating action limits such that you can generate those reference intervals to enable you to take action on any screen positive. So our system works quite simply. We choose to use a profiling system. As alluded to, this is a profile for MSUD. This is a profile for urea cycle defects. And so we're now looking at these as profiles. This is a profile contained by the marker metabolite and its respective ratios, glutaric aciduria type 1, MCAD, and so forth. So we use this approach to enable us, this multi-parameter profiling recognition system, and with an understanding of metabolic pathways to do these tests. So very simple. In the case of PKU, phenylalanine is up, tyrosine is down. With this ratio, it works extremely well, 100% positive predictive value. And you have to understand the pathways. The elevation of phenylalanine, the lowering of the tyrosine has obviously the PAH enzyme affected, or its cofactor. It gets a little bit more complicated when you have several substrates that get converted to their respective product, each becoming the substrate of the next enzyme along the pathway. So the complexity of understanding and making this diagnosis or increased risk for this condition requires you to be able to measure all of these, which can be done by mass spectrometry. And so this individual would have MCAD, and then you would have this profile for a reference range for PKU, and this reference range, an associated profile for MCAD. So we can measure all of these to identify 95. We can pick up a whole group of disorders easily and readily enough. So our approach for here is to develop this multi-parameter profiling system where we're doing away with the numerical values, and we just consider looking at a color-coded system, a heat map. So an individual in any cell for here for phenylalanine, this means that this individual whose value is 56 is between the normal range, the background is clear, so this is an absolutely normal result. Those who have an elevation will be red, the number will be red, and so forth and so forth. So you can use this system in combination with NGS to provide you with a very good way of identifying for these disorders. So for instance, this baby here with this profile in the urea cycle defect has arginosuccinic acid lyase. This baby here with a low citrulline and the high pyroglutamic acid, which comes from glutamine, has been identified with ornithine transcarbamylase. And if you reflect that back on the pathways, you can see exactly where they are. Okay, then we can do the MSUD, as you can see from that profile. We could do the MCAD as well, and VLCAD. And so you can plot, these are all our MCADs, and in here is a cohort of 154,000 babies, and you can have an algorithm that enables you via this 3D plot to identify those individuals with MCAD. And this individual who's outside this algorithm plot is just simply a carrier. Okay, so here's a case presentation. So this profile here has a profile that, for all intents and purposes, at an increased risk of VLCAD. Okay, we have algorithms out there by Piero Rinaldo's group from the Mayo, who provides us with an excellent service in terms of being able to use an informatics system to determine what action needs to be done on a profile that you get such as this. Okay, so in his system he would say, okay, it's an increased risk, so you need to do something clinically about it. Our approach is then to reflect back using a specific panel that I alluded to before, and we're able to determine the mutations using that very same single first sample of the filter paper, and we can predict we identified one pathogenic mutation, and then we found a variation of unknown significance. So for us, will the neonate require clinical management? Well, we're not too sure. So we have to proceed on for another test that is done by the Biochemical Genetics in New South Wales at Westmead, and that is to do with cultured skin fibroblast to confirm or exclude that by enzymatic methods, where in the cultured skin fibroblast, the elevation of the long-chain fatty acid is consistent with VLCAD deficiency. And so we have a biochemical phenotype that supports that single pathonomic mutation that we identify by next-gen sequencing. Here's a case, right? Here's a baby in NICU, lactic acidosis, hyperglycemia, unresponsive, and suspected IM. They asked for a whole exome sequencing panel, but we got a card at 2 hours of age. This card at the age of 2, we were able to undertake a acetol carnitine profile, even though the sample was collected at 2 hours of age. The elevation of propionyl carnitine and the C5 hydroxy isovalerol then told us very quickly from this acetol carnitine profile that this baby had holocarboxylase synthase deficiency. And so the defect lied in this enzyme here in the biotin cycle. The treatment for that baby who was quite ill at the NICU was just to give biotin, and that baby responded extremely well from that. It took us a few days later to identify the mutation on that, but you can see the process here. The synergy between the two enables us to do this type of testing. Here's another case where this is a real case, a baby 2 days of age, full term, 36 weeks gestation, unremarkable, 10% dextrose with heparin saline and so forth. And we did an acetol carnitine profile, and we got a profile that sort of looked like an MCAD profile, but not terribly convincing. We can do within our screening software system, do this 3D plot. We had 3,000 babies who were matched to the demographics of the case of interest. There are other babies out this way, but this baby should not be out there. So immediate action is put it through the clear R4S, and it scored zip. So that's a bit concerning. We, at this point in time, couldn't understand why that baby would be out there. So we did two things. We undertook the targeted panel for our next-gen sequencing, and then proceeded to ask for another sample. And this is the profile, and we found the baby to be homozygous for the common MCAD mutation, and about 6 days later we got another sample and confirmed the MCAD profile. But you can see how this has greatly assisted this in understanding that this baby had MCAD and not something else. In this individual, you can see that this profile, you would be thinking if you're using a discrete test that it might be an MCAD, but in actual fact this is just a normal fasting state profile where the C6 is less than the C8 and less than the C10. Don't have to bother doing anything else. That is unremarkable. The requirement, this is through the CLEAR group, to enable you to interpret all this information requires an enormous amount of statistical prowess, understanding of the biochemical genetics pathway. And so this is for the lysosomal storage disorder iduronidase, MPS 1, and Piero Rinaldo's group have run these continuous covariant adjusted centiles given the additional information to enable us, the users, and to screen for these additional orders, some additional tools. I believe at the end we're going to approach this sort of thing for newborn screening, where we simply got a heat map, whereas this individual will be quite normal, this individual is affected, and these bars will indicate which region, lysosomal storage disorders, acell carnitines, and so forth. So in short, can we find the cases? I think we can. Does early diagnosis do any good? I believe very strongly that it does. Does it do any harm? I don't think so, but our approach must be monitored very carefully, and can we afford it? These are all the questions. And so, in short, these inborn errors of metabolism are identified by mass spectrometry, in addition with second-tier next-gen sequencing, as I've shown you in these examples, works quite well. They're capable of identifying these disorders with very good positive predictive value in our hands. The pre-symptomatic identification brings both short-term and long-term benefits. They provide the opportunity of targeted treatment when the patient is well, and for the most, it's effective and inexpensive. We require a well-coordinated program to make this help, but we are now in great need of some system of bioinformaticians and the interpretation software as more and more things become and are screened. So that's my take-home message. Thank you.